I just want to take this moment to salute all of you and the foundation. I speak at a number of different family meetings, and I'm really impressed with how far the RYR-1 Foundation has come in a very short period of time. It's really a salute to everybody. As Mike said, I'm a pediatric pulmonologist and have had the opportunity to work with lots of patients with different neuromuscular conditions. And I intentionally didn't put RYR1 myopathy in my title because there are a lot of just general principles that go along in patients with any type of respiratory muscle weakness. And I didn't put RYR1 in there because it's, at least in my experience, there's variable timing of different events that lead to respiratory difficulty. And so I wanted to just talk conceptually, and I'd be happy to drill down deeper after the talk and after the talks this morning. So just want to put up some disclosure slide. I have the opportunity to work on behalf of a number of different pharmaceutical companies in the neuromuscular field, none of whom are involved in RYR1, unfortunately, at this point. But none of this has any impact on what I'll be speaking on. So if we start with what happens with a neuromuscular disease that leads to respiratory muscle weakness, you start actually with respiratory muscle weakness in one form or another. And the end point of that is where the respiratory muscles don't work well enough to be able to bring in oxygen and get rid of carbon dioxide. And we call that respiratory failure. However, I like to think of things in categories. There are a variety of different respiratory muscle groups and muscle and skeletal combinations that lead to respiratory dysfunction. And going from left to right, the primary respiratory muscle is the diaphragm. And so if that's weak, that causes issues. And then the chest wall and abdomen together form the thoracic cage, and that can become weak and can cause problems. And that can lead to spinal instability and scoliosis, which many patients with neuromuscular disease have. And then these kind of interact in a sort of a nebulous manner. If we go starting from diaphragm weakness, that primarily puts you at risk of diaphragm fatigue. And if you're taxing a weak diaphragm, that puts you in a bad position. And then the other thing that happens is that to clear your airways, you have to take a deep breath. And so if you have a diaphragm that doesn't work quite as well, airway clearance can become an issue, which puts you at risk of respiratory illnesses such as pneumonias. And when you get a pneumonia, that can cause primary muscle weakness acutely, and then can cause problems with further airway clearance problems, which can then alter the balance between diaphragm strength or fatigue and respiratory load. As far as the chest wall and muscle weakness, if you have a flaccid or weak chest wall, when you breathe in, the chest wall will actually go inward, and it decreases your ability to take a deep breath. That can lead to eventually the chest wall muscles becoming stiff and dysfunctional, which then makes it hard for you to take a breath. It sounds kind of odd going from a weak chest wall to a chest wall that becomes very stiff and causes a further burden. That then, over on the right, spinal instability causes you to tip forward, which causes what we call kyphosis, or to the side, which is scoliosis. And those are kind of, those together can compress the chest wall and spine. Dr. Spiegel will talk a little bit more about that later. But that can alter your ability to take a deep breath in addition, leading to low lung volumes. And the smaller your lung volumes are, or the smaller your lungs are, the harder it is to take a deep breath. So ultimately you get into a position where you have diaphragm weakness and then varying amounts of respiratory load, some of which can come acutely during an illness. And when that gets out of balance, then you are in the position of respiratory failure. And so if we look at how we can track this, for respiratory failure, we primarily look at carbon dioxide level. During a clinic visit, we might do what we call an end-tidal carbon dioxide reading, where you have a little canyon on your nose, and we measure the peak carbon dioxide that is in your exhaled breath. And if that's elevated, we say that you're having difficulty and are in respiratory failure. For airway clearance, there's something called peak cough flow, which, as the name implies, is the maximum flow that you can generate when you cough. And there's some ways of looking at categorization. If we look at the end-tidal carbon dioxide level, we primarily focus on it at night during a sleep study. And the range of normal goes typically from 35 to 45 millimeters of mercury. And so if you're within that range, we feel pretty good. And then we get really concerned if it's above 50. And so between 45 and 50 is sort of that transition zone. Then if we look over on the left for peak cough flow, the general feeling is that there's a paper in the adult literature from about 15 years ago showing that if your peak cough flow is below 160 liters per minute and you're acutely ill, it makes it very difficult for you to be able to cough and clear your airways well when a breathing tube is removed. And so people have focused on that. And then somebody extrapolated from a higher value of 270 liters per minute as the threshold below which, when you're sick, you may have difficulties. And so people typically now focus on 270 liters per minute for peak cough flow. And I put this up to say two things. One, it's nice to know what's normal, but when you're normal, and there's always the risk and the likelihood of losing function when you become sick. And so this is how I think of things. If you have a range of normal in the black at the top, and then a gradual movement towards having abnormal function, and when you get sick, you start from normal function, you can definitely go into a position of having significant respiratory difficulty. I say this because we focus on when to start respiratory support, and if you focus based on a number when you're well, you can only extrapolate how things are when you're sick. And I think all of us here in the room, whether we have RYR1 or not, become weak and don't do things quite as well when we're sick. And the challenge is knowing when you're in a position where when that happens, you drop to a concerning point where you may need additional support and may be at risk of a severe illness and hospitalization. And so in many neuromuscular conditions, this has shifted the focus towards being proactive and starting both airway clearance and having available respiratory support for ventilation. So I want to talk about each of these and the rest of the talk. The first thing I want to talk about is airway clearance. And to do that, let's talk about what happens when you cough. There are 4 or 3 distinct phases. The first is you take a big deep breath and you fill your lungs up as much as you possibly can. And then you immediately start to exhale, but your vocal cords close. And as you do that, you build up a large amount of pressure in the chest. And then when the vocal cords open, in the expulsive phase, you have a huge flow of air coming out of the lungs, ideally carrying mucus and whatever else might be in your airways. And so it's important because each of those 3 parts is critical to do an effective cough. So first of all, obviously, if you can't take a deep breath, that's going to be very difficult. If you don't have control of your vocal cords or your throat, which can happen in patients that have cognitive difficulties, such as cerebral palsy or static encephalopathy, that can be a problem. But in most neuromuscular conditions, that's pretty well intact. And then obviously the breathing out part, which involves your abdominal muscles primarily, if that's deficient, then you're also going to have difficulty with coughing. And so based on that, there are a variety of different ways that we can support coughing. The first would be, obviously, helping you take a deep breath. The second would be helping you breathe out forcefully. And the third, obviously, would be helping you do both at the same time. And then in addition, there's some other devices and medicines that we'll use to help with airway clearance. So if we start by talking about breathing in, on the bottom left is a little handmade device that has, there's a little arrow over on the, let me see if I can do this here, little arrow here, and what happens is that air will go in through this circuit into the patient, and then they breathe out against a valve that's set at a certain pressure. It's set at a high pressure so that it's hard to breathe out, and what we do is we have patients take a series of breaths in until their lungs are as full as they possibly can be. We call this breath stacking. And then we remove the mask and we have the patient breathe out as hard as they can. So it's a stepwise way of helping to fill the lungs and then have the patient breathe out as hard as they can on their own. So it's just supporting breathing in but not breathing out. This device in the middle might be familiar to many of you. It's the cough assist. It's the most recent version of it, the T70. And it can be set to just do a breath in. And then this device down here is called the Alpha 100. It's a device for doing just breaths in. It's very popular in Europe, in France in particular. And so it just is able to do breathing in support, but not breathing out support. You can do mechanical expiratory assistance, and this is a diagram of doing, we call manually assisted coughing. You can either do this by pushing, having your hands on the chest or your hands on the abdomen and the chest. And then what you do is you forcefully push down during exhalation on the chest or on the on the chest and abdomen or on the chest wall, helping a patient breathe out forcefully. In the hands of a trained provider, this is a very effective, can be a very effective way of providing airway clearance, but it's obviously very mechanically demanding and requires that you are lying down. You can't very easily do this sitting upright. So it's a perfectly valid, viable way of doing airway clearance that does require specific training. And so we can put these two things together if you don't want to do something that requires excuse me, equipment or electricity. You can do breath stacking and manually assisted coughing, perfectly legitimate way of doing things. Or many people will use the mechanical and exfoliator devices, one of which is the cough assist. There are a couple of other ones that are out at market. And this is a version of it. And what you do is you set a breathing in and a breathing out pressure. And we usually do a series of 5 sets of 5 breaths. So you do 5 breaths in, 5 breaths out. You take a break, you have the patient cough, or you help the patient clear airways by suctioning. Then you do another series of 5 breaths. The question that I get asked very often is, how often can you do it, or should you do it? And I say, well, how often do you cough when you get sick? And really, it's as much as you darn well need to. And so in the hands of parent, you have the latitude to do cough assist treatment as frequently as you need. Though when we have to put in orders for nursing, we have to come up with something. What I usually will do is recommend twice daily to make sure that the patient is comfortable using it, and then every hour as needed during an illness. And that typically works pretty well. I want to finish the airway clearance part by talking about other techniques that you might see or might hear of called for helping to mobilize mucus. And the important thing is that this can't be done on its own. It has to be done when you have an intact cough or you have a way of supporting the cough. So this shouldn't be done, what I'll be talking about shouldn't be done without a cough assist. It needs to be done with a cough assist or similar airway clearance modality. So this first device is called intrapulmonary percussive ventilation, or IPV. And it's essentially a fancy nebulizer where you can nebulize saline. And it's done under pressure, and it's done with some oscillating pressure, which essentially vibrates the airways and helps to shake mucus off the airway walls and makes it easier to clear. As I mentioned before, this requires an intact cough, but one of the advantages of this is that you can nebulize saline to help make thick secretions thinner and easier to mobilize. This next device is called the VEST, or high-frequency chest wall oscillation. It's a hallmark of therapy in another condition called cystic fibrosis, which is the most common genetic condition in Caucasians. And what this does is it inflates and deflates very rapidly and vibrates the chest. And that vibration helps to mobilize mucus. And again, with an intact cough, it's a very effective way of mobilizing secretions. And then I just want to touch briefly on there are medications that we can use that can help make thick secretions thinner and easier to clear. If you have secretions that are too thick, the first question is, why are they thick? If they're thick because they've become somewhat dehydrated, then you can use saline or concentrated saline, which we call hypertonic saline. If they're thick because of a chronic bronchitis and you have cells in there, white blood cells, that are there to fight off the infection, there's a medicine called Dornase alpha or Pulmozyme, which is very popular in cystic fibrosis, and that helps to break down the cellular components of mucus and make the mucus thinner and easier to clear. Neither of these are necessary or appropriate for day-to-day therapy in neuromuscular disease, unless there's some other difficulty in terms of secretions. But typically we don't like to use either of them chronically. The issue with hypertonic saline in chronic use is that it humidifies any secretions, whether they're thick, thin, or normal. And so if we use hypertonic saline for too long, we can run into the opposite problem of having too many secretions. And so they're both very effective in the right situation, but they have a therapeutic range that it's important to pay attention to. And then finally, some patients have trouble with having too much saliva, and so there are medicines that can be used to decrease the amount of saliva produced. And then standard typical things, allergies. Patients can get allergies. If you have increased nasal secretions during the spring, summer, or fall, that could be because of allergies, and so sometimes we'll use an antihistamine. And then finally, think about what happens before you vomit. Before you vomit, you typically get a lot of salivation, and so patients that have reflux, have recurrent vomiting or recurrent reflux up into the esophagus, can have hypersalivation. And so it's important to keep reflux in mind, even without projectile vomiting. That can be a source of increased upper airway secretions. So moving on to respiratory failure, I think the most important thing to remember is there are two components that are both important to pay attention to. The most important by far, in my view, is the interface. You can have the most wonderful ventilator in the world, but if the contact point to the patient isn't comfortable or tolerated, then the ventilator is not going to work very well. And so for nighttime support, the vast majority of people will choose a nasal interface. For daytime support, there are mouthpieces, and I'll show an example of each of these a little bit later. You can do mouthpiece support, and then if you have trouble with a leak out of the mouth, if you're doing nasal support, you can do oronasal ventilation. Some patients will choose the route of having a tracheostomy tube. And then there are some very rare situations where you can do full body support. There actually are modern versions of the iron lung, which many of you know was part of was developed when polio was an epidemic 70 or 80 years ago. They're not used very widely because there's some practical issues that make it very difficult to provide good care. There always are new nasal masks that come to market, and I put these up as just sort of general examples. The three on the top have a silicone interface or contact point to the patient. Many of them will have a little balloon like buffer that fills with air when ventilation is occurring, and that provides a nice soft air-filled contact point. The ones on the two on the bottom that are blue on the left and in the middle have a gel-filled interface, and many patients tolerate those very well because it's soft and they sort of mold fairly easily to the contour of the face. They each come with different contact points and headgears, and those are things that can, I think, probably end up causing the most challenge in terms of comfort and where the bands are put and then where the pressure points are. The three masks at the top have a contact point both on the nose and then on the forehead, which helps to distribute the pressure. One of the biggest challenges is trying to preserve the skin integrity on the nasal bridge. And when we have patients who are acutely ill in the hospital, that can sometimes become a big problem. This is a more recent device. We've struggled getting companies to design devices that are appropriate for kids. And I suspect that this child, because he's smiling, is either very new to having a nasal interface or was well compensated by the company that produced the slide. But be that as it may, there now are options for young children. There also are cannula interfaces, which fit into the nostril. Some people like these because they don't obstruct your vision as much as the triangular nasal masks do. Many people will switch between a cannula interface and a nasal mask interface just to alter pressure points. And then these differ with how the tubing that connects to the ventilator goes up and over the face. There's some other nasal interfaces that have different headgears. The one on the left has the addition of a chin support that helps to keep the mouth closed. And then the device over on the right is a newer interface called the Mirage that many people like, that has a silicone interface and then a single strap on either side of the mask. When we have problems with patients keeping their mouth closed at night to prevent air leak, we can put a mask over the mouth and nose, which is what the mask on the left is doing. And the mask on the right has been out for a number of years, and the first time I saw it, I was shocked that anybody would consider wearing something over the entire face. But many people actually like it. It's called the scuba mask. I think it's more of an avatar mask. And when presented in that manner, it's often well tolerated by our adolescent patients. And then there are ways of keeping the chin upright, chin straps to help prevent the chin from dropping down at night when you go into deep sleep, which then makes ventilation less effective. And finally, mouthpiece ventilation, or SIP ventilation, some people call sip and puff, is a way of providing daytime support through a mouthpiece that can be placed right by the patient's mouth, or if it's a patient that has preserved upper extremity function, the tubing can actually lie on his or her lap, and they can raise it to the mouth to use as needed. There are two different ventilators that we use. There's one in this image. It's called the LTV ventilator that can be set to do just mouthpiece daytime ventilation. This is the Trilogy ventilator, which also has a mouthpiece ventilation setup. And the tubing here is actually quite nice. It's articulated like a microphone stand, and you can move it around to position it just to where the patient wants. You can actually, has a great clamp, so you can take it off a wheelchair, you can put it on a kitchen table or on a coffee table or on a chair, wherever the patient may be, and quite useful in that manner. The last thing I want to talk about are ventilators. There are ventilators that are set for just nighttime use, which are cheaper than ventilators that are set for daytime use. And so if all you need is nighttime support, a nighttime non-invasive ventilator is perfectly appropriate, and you don't need all the bells and whistles of a continuous ventilator that you might use during the day. If you do shift to needing daytime support, then you can use, there are a couple of ventilators that are more robust and can be used continuously. And as I said before, they are a little bit more expensive. So if your child is or you are being started on non-invasive ventilation, if all you need is nighttime support, a nighttime BiPAP ventilator is perfectly reasonable. And then finally, I mentioned earlier that things change acutely, obviously, when you get sick. And so I think it's very important to have a plan going into hospitalization, whether it's for acute illness or if you're going in for surgery and dealing with the changes post-op from anesthesia and pain medication and sedation. And I think it's important to get set up with airway clearance and non-invasive support before it's needed during an acute setting. And so that's something that I think much of the neuromuscular community has begun to embrace and has been present in some of the recent clinical guidelines. And then to finish, if all fails, and I'm sure this will strike home for many of you, be a difficult parent and advocate for your child. I actually embrace having good, engaging conversations, and I look at it more as you guys being an advocate, but in many situations you're really an educator and instructing people that don't know about neuromuscular disease, or particularly RYR1, what needs to be done. And so I would encourage you to continue to advocate and rely on those of us that have had some opportunity to take care of patients with RYR1 or neuromuscular disease. So with that, I will stop and be happy to take any questions until I'm told to leave.